I'm Norman Swan. Welcome to this programme on the management of secondary lymphedema. At least 1 in 5 people treated for melanoma, breast, gynecological or genitourinary cancers will experience lymphedema following treatment for cancer. That's more than 8,000 new people with the condition each year. This programme looks at the prevention and treatment strategies. We're coming to you across Australia through the Rural Health Education Foundation's satellite network. And as usual, there are a number of useful resources available for you on the Rural Health Education Foundation's website, rhef.com.au. And also at the National Breast and Ovarian Cancer Centre's website, nbocc.org.au. Now let me introduce our panel to you. Andrew Spillane is Associate Professor of Surgical Oncology at the University of Sydney. Welcome, Andrew.
Thanks, Norm. Yeah.
Julie Thompson is a rural general practitioner and Manager of Primary Care at the National Breast and Ovarian Cancer Centre. Welcome, Julie.
Thanks, Norm.
Verity Ahern is a radiation oncologist at Westmead Hospital in Sydney. Welcome, Verity.
Thank you.
And Karen Shanley is a physiotherapy manager at Mount Wilga Private Hospital, and she's also President-elect of the Australasian Lymphology Association. Hello, Karen. What does the Lymphology Association actually do, Karen?
Well, we represent health professionals interested in the field of managing lymphedema primarily.
And what sort of professionals deal with it? I mean, because a lot of rural GPs will be watching this thinking, well, you know, they're going to tell me to refer to a lymphedema practitioner and I haven't got one.
There's a range of health professionals who would look after patients with lymphedema, including physiotherapists, occupational therapists and nurses, as well as remedial massage therapists working with patients in the community.
And is there a qualification?
There isn't at the moment, but we're working towards one.
Good, okay. Julie, and one of the reasons we're doing this programme is there's a new guideline out from the NBOCC.
That's correct. The National Breast Cancer and Ovarian Centre has developed a guide for GPs that will be available from May, both as a downloadable PDF file from our website and also through their divisions of general practice, that will give them a pathway to both help reduce risk and to manage people with lymphedema.
So let's just remind ourselves what it looks like when you see it. I'm sure many GPs will have already seen it.
Indeed. If you have a look at the first picture here, this is a lady who had breast cancer surgery some time ago and radiotherapy, and she's developed lymphedema of her right arm. And the second graphic you'll see is of a woman who had quite extensive genitourinary surgery and radiotherapy, who has quite severe lymphedema affecting her right leg. And this is an important reminder that we know a lot about breast cancer and lymphedema, but people often forget that genitourinary cancers, gynecological cancers and melanoma cancers, post-treatment, those patients are also at risk of lymphedema, and actually at the same rate of people who develop it after breast cancer. So we're looking, as you said, 1 in 5 people who survive treatment for those 4 main groups of cancers go on and develop lymphedema.
And it's not just the breast, just remind you, it's just not women with breast cancer.
Exactly.
And when does it start to present?
There's a wide range, anything from 2 months to 20 years it can develop, but 75 to 80% of people present within the first 12 months following their initial treatment.
Andrew, what's the pathology here?
Well, the lymphatic system's an integral part of human anatomy that drains excess tissue fluid back to the venous system, but it conducts along axial vessels that have one-way valves and through the lymph node fields. And so if you interrupt the lymphatic drainage by removing or interfering with the lymphatic fields, then you can get lymphedema in the limb because of that.
And is the actual interstitial fluid different from, say, the interstitial fluid when you've got, say, congestive heart failure and you've got ankle edema?
Well, it's a protein-rich fluid, and if it's left in the tissues, then it can certainly cause fibrosis and thickening, and it can get locked in the tissues. So that's an important reason for getting on and diagnosing it early and instigating treatment early to prevent that fluid from getting locked into the tissues, causing this fibrotic reaction and being locked in the tissues.
Who's particularly predisposed, Verity?
Well, I think anybody who's had surgery to the lymph node areas in particular, or radiotherapy to the lymph node areas, or combination. So But within those people, there'll be some who seem to have a higher risk than others, but it is totally unpredictable. We do know, however, that people who are overweight or are less active than others put themselves potentially at higher risk of getting lymphedema. I'm not sure what you see, Andrew, in surgical practice.
Well, again, as you say, it's unpredictable, and the thing to note is that it can happen even in minimal interventions. Certainly with sentinel node biopsy being more commonly used now in breast and melanoma, breast cancer and melanoma, the incidence is lower, but still we occasionally see people, particularly in lower limb sentinel node biopsy, having lymphedema, usually mild, and similarly with breast cancer, occasionally you get that upper limb mild lymphedema. But it seems the greater the surgery, the greater the intervention, and then particularly if you add on top of that radiotherapy, a much higher incidence of getting severe
So it's
lymphedema.
always related to lymph node clearance or lymph node treatment?
Yes, yes. That's without interfering with the lymphatic drainage, then you're obviously not going to get lymphedema. So, yes.
And so for GPs who've heard about sentinel node biopsy but need reminding what it is again, we're talking here about getting the key node that's the first drainage from the affected area.
Well, the sentinel node is an anatomical concept that it's whichever part of the body the tumour's in, there's a primary lymphatic drainage from that part of the body. And if instead of what's been done in the past with breast cancer and melanoma of clearing the whole obvious lymphatic field, you map the patient, see where the lymphatics are actually draining to, and take out the lymph nodes that are most likely to have the cancer in. And not only that, you can focus on that lymph node more carefully than you would if you took 30 lymph nodes out. So you can look at that one extra carefully and do extra.
And it really does
assessment.
reduce the risk of lymphedema?
Unequivocally, there's level 1 evidence that sentinel node biopsy has less morbidity, including lymphedema, than full node dissection.
So to what extent are rural surgeons doing it?
I think that the bigger centres are certainly taking it up. There are techniques in breast cancer of using blue dye only and not having to use lymphoscintigraphy that have been shown in good hands to be reliable as well. So it can be used broadly across the community. And certainly it's the equivalent, if not slightly better, maybe staging procedure is taking all the lymph nodes out because of the closer assessment of the lymph nodes that you can undertake.
So GPs, when they're referring their women for breast cancer surgery, need to advise them that they really should be looking around, even if it means a bit of travel for somebody who does sentinel node?
Well, I think that the patient has to be aware of it. It's for people with clinically negative axillas, so if they've obviously got a nodal disease in the axilla already, or the sentinel node is positive, the standard of treatment is still to have a full axillary dissection in breast cancer, or also in melanoma. If it's a positive node, you need a full nodal field dissection. But it's certainly something all women with early breast cancer should be made aware of and have it discussed with them.
So with radiotherapy, Verity, is it just with inguinal and axillary node radiation, or can you get it with radiation, say, following lumpectomy?
Following lumpectomy, the radiotherapy will only be to treat the breast, not the nodal areas typically. You can get edema of the breast though, even in someone who's had a sentinel node biopsy. The edema in the breast in that setting, the breast conserving setting, is something that might develop to a mild degree during the radiotherapy treatment and build up for a few months afterwards, but it spontaneously resolves with a little more time, so it's really not a long-term problem.
And what proportion of people get lymphedema after axillary or inguinal treatment?
If you have an axillary dissection and we don't irradiate that in the breast cancer patient, then I usually quote the women about 5%. But women who are advised to have axillary radiation in addition to axillary surgery by way of dissection have a much higher risk of lymphedema, probably about 30%.
There are medications, aren't there, that can make it worse, Julie? Or can maybe increase the risk?
There are medications that can make it worse. I don't know that they induce lymphedema in someone who doesn't already have it, but some of the antihypertensives, the calcium channel blockers, the non-steroidal anti-inflammatories, hormone replacement therapy, the glitazones that are used for diabetes, they all cause peripheral edema in some people and therefore could potentially exacerbate lymphedema rather than being a primary cause.
Many myths about this around, Andrew?
Yes, I think there are a lot of myths about things that might precipitate lymphedema. For instance, virtually every patient you'd ask would have been told not to have venipuncture on that limb, to avoid having blood pressure measurements on that limb, that going on a long haul flight or even a flight to Melbourne or Queensland can bring on lymphedema. And I think there's really little substantiating evidence for those things. They're more anecdote related, and I wouldn't encourage people to believe them. It's more being sensible, being honest with yourself. If you've got things that worry you that could be lymphedema, you go and tell them to your doctor and make sure you get referred to the appropriate people.
So what are the known precipitants?
Well, surgery and radiotherapy are good precipitants.
Right, okay. Apart from you and Verity, what are the precipitants?
Other major traumas. People who are overweight are more likely to get it for those procedures, and people who have complicated post-operative courses with infections and particularly abscesses and things in that nodal field as well, it certainly causes more scarring, and similar, I guess, to radiotherapy, increases the risk of radiotherapy through further scarring and obliteration of presumably residual pathways.
Now, we've got a case study tonight for you, and we're just going to follow her through in her course and see what happens to her. She's called Samantha. She's 53 years old. She's a retail manager, and she's recently been diagnosed with breast cancer. She comes to see Andrew to discuss her treatment options. So what's your spiel for Samantha, Andrew?
Well, it's a long spiel. It probably takes about an hour.
Let's focus on the lymphedema bits.
But most patients with a small tumour would be offered breast conservation surgery, which they'd have to have post-operative radiotherapy for, or a mastectomy. And as far as assessing the lymph nodes, if they're clinically node negative, if there's no obvious disease on ultrasound in the axilla, then you would offer them a sentinel node biopsy on the strength of multiple randomised trials that show that it's equivalent in terms of staging and lower morbidity. On the understanding that if the sentinel node is positive to any significant degree, then the next step would obviously be an axillary dissection in breast cancer or in melanoma, or wherever it is, whichever regional field it is. But,
so, Karen, is there any sort of limbering up that can be done to sort of get yourself into shape? I mean, given that if you've got breast cancer, you're probably going to be operated in the next week or 2 weeks, so there's probably not a lot of time to sort of build up your pecs.
That's true, but we would certainly encourage patients to think about the sorts of exercises that they can be doing after surgery. So we want to make sure that they maintain their range of motion in their affected arm or their operated side after surgery. So we would be talking to them early about the range of motion exercises they would be doing post-op.
Such as?
Well, such as shoulder range of motion, some scapular range exercises, but it would all be gentle immediately post-op until their wounds heal. And then once they've healed, we'd be moving on with that range, but also then looking at progressed strength training from that point on.
Okay, we'll talk about that in a moment. Mm-hmm. Now, at surgery, Samantha was sentinel node positive and she had an axillary clearance performed. How does this change things for her post-operative course, Andrew?
Well, should be in hospital for longer. I mean, sentinel node biopsy is a day procedure. Lumpectomy and sentinel node biopsy would either be home the same day or the next day, whereas with a drain in, the patient will often stay in hospital for 4 or 5 days unless they've got good support, APAC nursing for the community care, and also the patient will have a longer post-operative recovery from the surgical intervention, and would have been informed beforehand this is the procedure that has the higher risk of lymphedema, and therefore this new set of precautionary things will come in, extra advice on how to prevent lymphedema and shoulder mobilisation and various other things.
So what does the guidelines say here, Julie, that should happen at this point in the course?
I think it's really important at this course that Samantha's educated about early warning signs, that her GP inquires when he or she sees her as a routine, that she asks about change in mobility, change in symptoms of the arm or the leg in other patients, because I think often, unless you raise the awareness in patients, they'll often put up with the symptoms. And the key message for us at this point to GPs is that early intervention can minimise the impact of people that are at risk of developing lymphedema, and even those who go on to develop it.
So it is worth picking it up early. You can make a difference.
Absolutely. You can reduce the morbidity, you can reduce the loss of function of the arm, and therefore improve the quality of life for these people if you can intervene early.
Karen, I remember once interviewing a professor of physiotherapy at the University of British Columbia who invented the dragon boat racing for women with breast cancer. I mean, that's just an amazing story where she just didn't believe what the previous advice had been, which was not to exercise, to rest it, you might make things worse. But she found that, in fact, really quite vigorous exercise, effectively building up that arm, just make a huge difference.
And certainly that used to be the advice that we would give to patients, that they shouldn't be doing a lot of exercise with their affected limb, but we've certainly changed our point of view now based on research evidence that keeping that limb strong reduces the risk of developing lymphedema rather than increasing the risk. So dragon boat racing is an example where they're using quite vigorous exercise, but they have that progressed strength.
Bit hard if you live in Alice Springs.
True. But anybody can be doing progressed strength training to make sure that their limb is nice and strong and so able to manage anything that they need to do in their daily life.
And there's also skincare advice. Just tell us a bit more about that. It's easy to say skincare. What actually are we talking about here?
We want to make sure that patients keep themselves clean, obviously good personal hygiene, but also cleansing of the skin of the affected limb. Looking at softening agents like moisturisers and any sort of antifungal care that they might need. So making sure that their nail beds, etc., don't have any fungal growths because they want to avoid any risk of infection.
So it's all very well saying antifungal care. You know, it's not something that you actually expect or or can see. I mean, are we talking about regular antifungal preparations? I mean, Julie, what are we talking about here? If your nails go green, panic.
No, it's simple things like using a moisturiser so that you avoid cuts to the skin, which is an entry for bacteria. It's wearing gloves when you garden and avoiding unnecessary trauma like that. And
do you recommend alcohol rubs, in terms of hygiene after being to the bathroom or something like that?
Alcohol can be very drying. So, in fact, in some people with sensitive skin, we'd even be telling them to avoid soaps, use more sorbolene, both-based moisturiser to both bathe and moisturise afterwards, to, when they're cutting their nails, to cut them straight across so there's no damage to the cuticles. Sensible preventive measures like that are the essence of it.
I think a key point for Samantha at this point is that she's getting a lot of information about a cancer as well as this information about preventing lymphedema, and it doesn't hurt to re-emphasise these things over and over because she'll probably have chemotherapy as well as the radiotherapy, and there's a lot of good things happening in this woman's life.
Verity?
It is interestingly often only when people get to radiotherapy that they've got time to absorb the fact that they've had a diagnosis of breast cancer and they've gone through all of this, and suddenly they're beginning to see the light at the end of the tunnel because radiotherapy it's the end, and they are looking to the future. Well, what do I do next? So that's a good opportunity as a radiation oncologist to be going through those prevention issues with them again.
And do you refer early? I mean, given you'll see a lot of women from rural areas coming to have radiotherapy.
Yeah, I think it's an ideal opportunity for women from rural and regional areas to link in with a occupational therapist or physiotherapist, depending on who manages lymphedema at the hospital that you work at. And certainly anybody who is undergoing radiation to nodal areas after surgery, I would automatically send them to see a lymphedema specialist.
It's 18 months down the track for Samantha, and she comes to see you, Julie, complaining of tightness and swelling of her affected arm. She's really it's uncomfortable wearing her wedding ring anymore, and it's been a gradual onset, but now she's pretty much aware of it, although it's fluctuating day by day. What are you going to do about Samantha now?
I think the first thing to do is to exclude a tumour recurrence as the cause of her lymphedema. Although it's been a gradual onset rather than acute onset, I think you still need to consider it. So careful attention to the history and clinical examination, examining the supraclavicular nodes, the axilla, the site of the previous surgery, reviewing any medical imaging, and maybe ordering it if it hasn't been done recently. And if you suspect a recurrence, then you need to refer her back to a regional treating specialist. If you have no concerns about that, then it's important that you first of all assess the extent of her lymphedema by measuring it, examining her arm. If it's mild, you may go through the precautionary measures we've discussed, but if there's any particular disparity between her arms, then you'd be considering referral to a specialist lymphedema therapist to work with you to help Samantha manage your lymphedema.
So Karen, is there a special way of measuring the arm?
Norman, there is, and earlier I filmed a segment with a patient demonstrating this. Hi Julie, I'm Karen. You've attended today for us to have a look at your arm because you're concerned that you may have lymphedema. So we've gotten you undressed so that I can have a really good look at your arm, both sides. What I would like you to do to start with is just to raise your arms up for me so that I can look at your range of motion in your shoulder. That's very good. Okay. Can you turn around for me? What I'd like you to do now is take your arms out to the side. That's good. And back down. And what I'm doing there, Julie, is having a look at your shoulder girdle to make sure that they're symmetrical, and also just having a little feel of your chest wall because that's somewhere that lymphedema can start even before we can find lymphedema in your arm. All right, Julie, that all looks good. What I'll get you to do now is just to sit down for me. And I'd just like to have a look at both of your arms. Good. I'm just looking at the texture of your arms, looking at the blood vessels and the tendons so that I can see that we can see them the same, and also looking at the back of your hands, right, and around your elbow. But that's all good. Okay. Julie, we've measured your right side. Now what we're going to do is measure your left side in the same way so that we can compare your right and left sides. So we're going to start again measuring the circumference around your palm. Good. And I'm just writing your measurements down as I go because we need to be able to come back and compare them at a later stage as well. Now I'm putting a mark at your wrist because your wrist now becomes our 0 point, and we're going to take our further measurements from there. And I need to make some length measurements along your arm. So I'm just going to pop some marks on your arm every 10 centimetres. Good. And then I'm coming back and recording the circumferences at those locations. Just relax, keep nice and still for me. That's good. Moving up past your elbow. Good. Excuse me, let's move my sheet. Good. And that's all our measurements. Thank you, Julie.
And for all you time-pressed GPs, that took well under 3 minutes. So it's not too long. Now, what's the difference got to be between the two arms for you to, to be ringing the bells?
With a patient's dominant arm, they may have a difference just simply based on muscle bulk. There is talk about 2 centimetres being a significant difference. However, you would really be looking at the patient's limb and making a clinical judgment about whether there's lymphedema present or not just simply looking at the circumferential measures.
Verity, what's your rule of thumb?
Well, again, in patients who've never had axillary dissections, you'll often find a centimetre difference between the dominant and non-dominant arm.
More for a tennis player.
Well, absolutely. So I don't have a rule of thumb, I must say. I certainly do the measurements in patients who are concerned. but I'll tend to refer a patient on even if the patient reports that they're aware that it feels different or heavy.
Andrew?
Yeah, I think you have to have a low threshold for referral. I mean, it obviously depends where you're working, and we're spoilt in the middle of Sydney, obviously, but I think if the patient's anxious about it, and a lot of them have read a lot about lymphedema and are very concerned about the possibility, then it doesn't hurt to have them formally assessed and get some more advice and reiterate the advice. So I would refer them early if there's any doubt. I mean, I often just check, and the tissue turgor, particularly at the top of the arm early on, I find is useful. And if I think there's something happening, then I'd refer them on and give them advice.
And one question here was, Julie, from rural Victoria, do all patients have to see a lymphedema practitioner? It can be difficult to access the service, at least in my town.
That's right. There aren't specialist lymphedema practitioners in all rural areas. It really depends on the severity of the case and how much it's interfering with the person's quality of life and function. As my colleagues have said, they have a measurement at which they would refer. Often simple strategies, teaching people to maintain normal exercise, use of the limb, monitoring their weight, because BMI is a risk factor, good attention to skin care, and having a plan so they know what to do should they develop a complication such as an infection is enough for a lot of people. If there is a specialist lymphedema practitioner available, then it's good to work as a team. They can reinforce the messages, because compliance sometimes can be an issue, and they can work with you to develop a self-management plan for the person.
And the second question is from from South Australia. I have a patient who's having trouble complying with his treatment for secondary lymphedema. He's also feeling quite depressed after his cancer therapy. What strategies or advice can you get for helping this patient improving his adherence to treatment?
I think part of the comprehensive care of these people is due attention to their psychosocial care, because it can become a chronic problem, can interfere with their work, their life generally. So you do need to be aware that depression can be an issue. And for people that develop a chronic condition after cancer treatment, they are able to access the same team care arrangements, EPC items that other people with a chronic illness can. So it's important that the GP is aware that for these people, if they develop lymphedema or depression after cancer, that whole gamut of...
They will respond quite well to cognitive behavioural therapy, for example.
Yes.
And problem-solving therapy. So Karen, take us through then the staged approach from initial treatment through to, you know, if they just seem to be quite early in the course of lymphedema versus having quite established lymphedema.
Well, certainly if patients present with early lymphedema, then the sorts of management techniques that we would need to use would be much less labour intensive. We're looking primarily at education of the patient about how to look after their limb. We may teach them how to do some sequential massage.
So tell us about the sequential massage. We'll come to it in a bit more detail later, but just briefly.
Sure. So we would be trying to move fluid from the affected limb towards healthy areas of their body.
So literally sweeping the arm and trying to get it over to the contralateral side.
That's right. So
literally
we would
imagine
be
yourself pushing the fluid.
That's right. We're starting in the centre of the patient's body, so their trunk, and then moving to the proximal aspect of their limb and then distally on their limb. So
oh, I see.
sequentially moving the fluid.
So in other words, you would start massaging here or under the arm and then...
And move down the limb.
Why would you do that? Not start... I would imagine you'd start here and then push up.
A bit like a traffic jam. You want to clear the traffic at the front of the traffic jam before you can move the cars behind.
Oh, right. And at this stage, would you be doing anything like bandaging at this point when you got
Not
early
if it was very early lymphedema. We would possibly prescribe a compression garment for the patient to use to help to provide some external pressure on the limb to maintain the size.
And is that during the day, at night, or all the time?
Generally, it's during the day. It depends on what the therapist prescribes for individual cases, really. But if we get to the patient at that early stage, that may be enough to prevent them developing more severe lymphedema.
And then you just watch their girth, their circumference, and see what's happening.
That's exactly right. So those circumference measurements come in handy to monitor on an ongoing basis. And if their symptoms change or their lymphedema becomes worse, then we need to look at them again.
And how often is that you can get somebody who just manages it like that? They have good days and bad days, and sometimes they've got to do it and some days not.
Look, in all honesty, it's becoming more common for us to be able to do that. There's much better awareness within GPs, within health professionals in the community about lymphedema, so we're getting referrals earlier and earlier. And certainly there's more options now for people with lymphedema management in the acute setting rather than needing to be referred to external providers.
Okay, you've got to bring out the big guns because it looks, you've got a big limb here and it looks as if it's becoming consolidated.
Mm-hmm. So that's a much more intensive treatment. It happens in 2 phases. So there's an intensive or a treatment phase where we're trying to reduce the patient's limb size, and then there's a maintenance phase where we're giving the patient the skills to manage their limb at home.
Just take us through then.
So the main treatment methods in complex physical therapy, there's 4 basic steps. So there's specific sequential massage that we've talked about already. There's multi-layer lymphedema.
But this is where you do it rather than leaving it to the person or the partner to do it.
So basically it takes a therapist about 45 minutes to do this massage, so it's quite a long time for therapists to be with the patient. Then we're looking at multi-layer lymphedema bandages. We're still looking at their skin care and making sure that we're preventing any infections, and then we're encouraging the patient to exercise in those bandages.
So take us through those one at a time.
Okay, so the massage, and there's a slide of the massage. We're looking at specifically what's happening with that patient in terms of their past medical history and other surgeries that they may have had, so that we can map the route for the massage. This is an example of a lady with right leg lymphedema, and here you can see that we're moving fluid from her affected right leg to the contralateral inguinal nodes, so the other side of her body, to the abdominal nodes and to the ipsilateral axillary nodes.
And the bandaging?
And the bandaging is multi-layered bandaging. It's a semi-rigid encasement, so we're using short stretch bandages, the idea being that we don't then dissipate the pressure that is built up by the muscles moving within those bandages.
So it's a fairly even pressure over the whole limb?
It's a graduated pressure, so we're aiming for more pressure distally and less proximally so that we can move the fluid up and out of the limb.
And that's pretty effective?
We find it's very effective.
And the compression garments, because there's a trick to getting them on as well. What advice do you give for that? So
compression garments are a prescription garment, so it's really important that patients see a therapist who knows what they're doing with garment prescription, and then once they have the garment, that they're donning that garment correctly. If they have difficulties with garment application, there are tools that they can use to help get the garments on and also the garments off. Particular frames, or donning frames they're called, easy slides, which is the little blue triangle in the corner down there, and even just as simple as rubber gloves, which help the patient to have more traction as they're holding onto the garment, can make all the difference with the patient getting the garment on and off.
So your aim there is to get the limb down to the smallest possible circumference.
That's exactly right.
Intensive therapy, and that's daily therapy that you give when you're really, so it's really heavy duty stuff. And when you get down to a steady state, is that when you go on to self-management? The person looks after themselves?
So once we get the patient's limb reduced, or as close to normal as we can get it, that's what we call a plateau. So we're looking for at least 3 days where their measurements maintain, and then we would consider that we can measure them at that stage for a compression garment, and then we would go on to educating them for home management, so teaching them to massage and things like that for home.
So I had a question from a GP in rural Queensland. Is hydrotherapy worthwhile here? Hydrotherapy
is fantastic for lymphedema patients because you can get a lot of pressure on the limb when the patient's got their leg down deep in the water, for example, which is similar to the pressure that they would get from a garment. So they can get the same benefits of that external pressure, which allows the muscles to pump the fluid more effectively out of their limb. So
you've just got to find a hot spring in your country town.
You do. You don't want it too hot, though.
Right. So, and do you find self-management compliance or adherence an easy thing to get people to do, Julie?
It's the same as any chronic condition, so that there are some people that are very good at complying to your instructions, there are some that aren't. But I think the more that the team reinforces the same messages and that people understand why they're doing it, so the reasons behind the skincare, the exercise and so on, then the better the compliance.
I think that it's really important to empower the patient early on in all this and to tell them that they have to learn what makes their lymphedema worse and how to control it and seek advice and help when they need to, but they really have to be the centre of their lymphedema management and know what resources are available to them. I think that's absolutely important.
Because often the symptoms will show up before the circumference starts going up.
But also most patients can manage their own lymphedema with good advice and some basic education, and they can look after their lymphedema themselves. And I have many patients, particularly upper limb lymphedema, that don't need a compression garment, but they use it when they need to or when they know they're going to do something that brings it on. And it's just a chronic grumbling condition in the background for them. And then you get these more severe people that need that intensive therapy to get it back under control.
Julie, there's a question here from a New South Wales general practitioner about the differential diagnosis of DVT and lower limb. You know, people who've had cancer, who had chemotherapy, are at greater risk of DVT. Who've had surgery are, and you might have a femoral DVT. How easy is it, and should you be doing investigations for DVT if someone develops lower limb lymphedema?
If someone presents with an acute onset, then there are two important things you have to exclude. One's a tumour recurrence and one's a deep vein thrombosis. So a duplex scan would become very important. And when the GPs get the opportunity...
So the history of onset is very important.
Absolutely. A gradual versus acute onset would really give you some clues, as well as your clinical examination. And when the GPs get access to the guide that we've developed, one of the key things that we deal with in that guide is acute presentation and the important things you need to exclude.
Let's go to another case study, because we're leaving Samantha well under the care, and she's doing extremely well. Jeffrey's 56. He's had melanoma surgery and inguinal node clearance 4 years ago, and he developed lymphedema 9 months after that operation in his right leg. He's overweight, he's got high blood pressure, and because he can't see his feet that much, poor foot and skin care. He drives a taxi, so he's pretty busy and hard worked and sitting a lot of the time. And he's not had time to see the lymphedema practitioner since his initial assessment. And he's come to see you today, Julie, in between shifts, because his leg is really sore. And when you undress him, it's looking pretty red.
Well, Jeffrey is presented with cellulitis, but as we just mentioned, it would be really important to exclude a DVT in him. And once you were confident that that wasn't the case, he's in the urgent, initially he needs his cellulitis treated, and then we need to deal with those many important risk factors that he has. So in the short term, it sounds like he's got reasonably severe cellulitis, so he would most likely need intravenous therapy, probably hospitalisation or hospital in the home, bed rest, elevation, fluids, and so on. If it was just mild cellulitis, you could possibly just treat it with oral therapy. But I think Jeffrey's going to need intravenous.
Because presumably it's a risk factor for worsening of his lymphedema in any event.
Cellulitis always has to be taken very seriously in people with lymphedema, because it can worsen their long-term prognosis. And people that get recurrent episodes, we may put on prophylactic antibiotics just to prevent those recurrences.
And presumably he also could be on medications, which, if he's got hypertension...
He could. He's hypertensive, so it's important to check he's not taking a calcium channel blocker.
So if he was on nifedipine, you might change him?
Indeed. We need to look at the fact that he's got a sedentary occupation, so his leg is probably dependent and not getting much exercise while he's working, so we need to look at developing some exercises for him. He's overweight.
If he were to have, say, a sugar of 6.9, is pre-diabetes a risk factor for lymphedema?
No.
But it is for cellulitis.
But it is for cellulitis, so you've got that complication. But as I said earlier, some of the diabetic medications can worsen lymphedema, the glutazones. So diabetes is another important comorbidity for people with lymphedema that has to be dealt with very carefully.
And prednisone's a risk factor?
Yes, it is. Prednisolone and hormone replacement therapy, non-steroidal anti-inflammatories can all worsen lymphedema.
So has your new guideline got a consumer education part to it as well?
Yes, it has. We've developed not only a health professional's guide but also a consumer booklet that, with a tear-off at the back, that GPs can give their patients to give them information about skin care, foot care, risk factors, precipitating factors and general care for themselves with lymphedema.
So Karen, would you recommend somebody with lower limb lymphedema see a podiatrist to keep themselves in shape?
Absolutely. It's always good for the patients to have good foot care, because certainly their feet can be a major source of infection, and again can cause the onset of cellulitis if they don't have the appropriate foot care in place.
As long as the podiatrist washes their hands.
As long as the podiatrist does the right thing too, of course.
Are there any drugs that can help? Some people try diuretics.
There's no evidence that diuretics have any beneficial effect in treating lymphedema.
And there used to be these things called benzopyrones. They're not. What were they? They were.
I think they are still used by some people. They have some potential bad side adverse effects, and there is no evidence that they make any difference at all.
Surgery? Some people have tried sort of hooking the lymphatic system to the venous system, haven't they?
And techniques of liposuction and microvascular lymphatic to venous anastomoses have been described. Again, they are really only done in centres of real dedicated expertise, and they're experimental and not widely available. I'm not aware of them being used in this country.
And the risk is it would make it worse.
I think you can always risk making it worse, and the sort of regimens that are involved in this are very much involve a committed patient being prepared to wear stockings constantly, forever afterwards, and they can get significant reductions in limb volume, but at a very major time and energy commitment on their behalf.
Not to mention the surgeon's part, presumably not easy surgery.
No.
Karen, I think it was a group in Adelaide who were studying jiggling machines. You know, you would stand on something which jiggled you and moved it. I mean, I'm not making too light of it, because in fact they were doing randomised trials of it. Do these machines help?
A lot of these machines are quite helpful for lymphedema, but certainly they don't take the place of conservative management, and I think it's important that patients, if they are going to, I guess, put money into their lymphedema management, that they look first at conservative management.
Do the basics first and then move on.
Yes.
What alternative therapies do you find people using, and are any indications that any of them work? Really?
There's a range of natural remedies, various vitamins. There's a whole range of things that people use. Some people have been using laser therapy, and Andrew could probably speak to that.
Where do they point it? Andrew?
There are clinics around that do it. St Vincent's Clinic does it and says that it's beneficial, but I'm not sure about that.
So in other words, don't give up the basics. You want to try something else that's an add-on, but it's not instead of.
I think whatever works for an individual. I mean, you know, everyone should take control of their problem and try to manage it as best they can. And if it's working for them, I wouldn't say it was rubbish, but there's little evidence in this area as well.
And some people are using pumps, pneumatic pumps. How do they work? Or if they work? Is this like old-fashioned cupping, really putting a suction on the skin?
Pumps can be a tool that's used by therapists, not done extensively in Australia certainly, but there's still a need to make sure that all those central areas are cleared, that the top of the affected limb is cleared, because otherwise you're just pushing fluid from one spot to another area and it can't escape from the limb. So the patients can actually build up cuffs of that fibrotic tissue that Andrew referred to earlier that make their longer term management much more difficult.
So what are your take-home messages for people watching, Karen?
I guess my take-home message would be don't ignore any swelling and get onto it as early as possible.
Verity?
I think prevention, and also listening to the patient even when you don't think there's a problem, but the patient's aware that there might be.
The patient is boss. Julie?
I think too, for GPs to be proactive, when you're reviewing your patients that have had cancer treatment in the past, particularly in these 4 main groups of cancers, to ask, to inquire, because people will often put up with mild symptoms and not understand the significance. And in people with developed lymphedema, I think it's really important to develop a comprehensive care plan with them so they take responsibility, they can self-manage, that you have a team supporting them, and they also know what to do should they develop cellulitis or any other of the important exacerbating factors.
Actually, there's a late question coming in from Tasmania asking about prostate cancer. Presumably prostate cancer treatment either by Which is probably for you, Verity, either by brachytherapy or external beam. That does involve the lymph nodes, so you wouldn't be too worried about that in terms of.
That's certainly right. I mean, the early prostate cancer patient who's suitable for brachytherapy, we're not going to be concerned about the prostate cancer having spread to the nodes and the glands needing to be treated, so I wouldn't be concerned at all. The majority of external beam radiation treatment to the prostate also doesn't include the nodes. Occasionally it does. So, you will get the very occasional patient who's had more extensive pelvic irradiation developing edema, even penile edema, but it's pretty uncommon.
Interrupted the flow. Anything else, Julie, in your take-home messages?
I guess early intervention can make a difference. So the evidence shows we can improve people's quality of life with lymphedema, so don't ignore it.
Andrew?
I think good sound messages from everyone. I think the patient should put themselves at the middle of the problem and take charge of it to whatever extent they can and seek good advice. But it really is less often, particularly in breast cancer now, because of sentinel node biopsy's influence. But it is a real problem for those who get it, but they can usually manage it themselves if they do it sensibly.
And they're starting to do sentinel node and melanoma as well, so the lower limb stuff should be becoming less common too.
Well, again, it's a staging technique or test, and if it's positive, then still most people are having a clearance and getting lymphedema at the same rate as before. It may just bring forward when they have their lymphedema and hopefully improve their chances of long-term survival, but that's yet to be proven.
Look, thank you all very much. Interesting and important stuff. And I hope you've enjoyed the programme too on the management of secondary lymphedema. Now, if you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. The National Breast and Ovarian Cancer Centre has also developed a range of resources, and that includes resources for health professionals and consumers. And they're at nbocc.org.au, nbocc.org.au. Some of them are not available yet, and they'll be available around May or June, so keep your eye out for them. Thanks to Dragons Abreast for letting us use their photographs, and if you want to know more about them and jump in the boat, you can go to their website, dragonsabreast.com.au. Our thanks to the National Breast and Ovarian Cancer Centre for making this programme possible. But don't forget to complete and send in your evaluation forms and register for CPD points by completing the attendance sheet. And thanks to you for taking the time to attend and contribute. I'm Norman Swan. From all of us, bye for now.